Assalamu alaikum, dear students. I am Dr. Muzammil and I welcome you all in today's class on blindness. Before starting the class, let me share with you a case scenario. So, Abdul Ghaffar, a 65 years old male, is experiencing diminution of vision for last few years. He is an illiterate person and is very poor. He is very ignorant as well and has not consulted the doctor till now. At present, his vision is so low that he is not able to perform his day-to-day activities. Now, as a public health person, can we be of any help to him? Coming to definition of blindness, WHO defines blindness as visual acuity of less than 3 by 60 using Snell's chart, or inability to read letters or decipher symbols at a distance of 3 meters in daylight, or inability to count fingers at a distance of 3 meters, which is equivalent to a vision of 3 by 60 or less. Now this is the picture which shows how we test the visual acuity. Coming to procedure, we have to ensure that we have good natural light or illumination. We have to explain the procedure to the patient. Wash and dry the occlude and pinhole. We have to test each eye separately, the bad eye first, and position the patient either sitting or standing at a distance of 6 meters from the chart. Now here we see a person has been seated at a distance of 6 meters from the chart. How do we calculate this visual acuity? Visual acuity is expressed as a fraction. The numerator is the test distance and denominator is the letter size. So this is the chart which we use in our setup. So the numbers below the letters shows the size of the letter. So visual acuity, if a person is able to read the topmost letter, we say that the visual acuity is 6 by 60. And if a person is able to read the bottommost line, we say that the visual acuity is 6 by 6. So how we infer the visual acuity? Visual acuity of more than 6 by 18 is taken as normal. Visual acuity of less than 6 by 18 to 6 by 60 is considered as low vision, whereas visual acuity of less than 6 by 60 to 3 by 60 is considered as economic blindness. The uniocular blindness is not considered as blindness. Blindness is not only an economic and a social problem, but also a health problem, because it results in premature death, which can be due to accidents or other similar causes. Coming to problem statement, globally we see that about 180 million people are disabled visually due to low vision, including 45 million who are totally blind. 1 to 2 million are added to this pool each year. Out of this 45 million, India contributes about 7 million cases. 80% of these are either preventable or curable, provided they have the availability of services and people take active measures. According to national survey, the prevalence of blindness in general population is 1.1%. In children between 10 to 14 years, it is 6 to 7%, and among elderly, which is 60 years and above, it is about 8.5%. Coming to causes of blindness, the most common cause is cataract, which means opaqueness of the lens. It contributes to 60% of the cases of blindness. After this, we have uncorrected refractive errors, which contribute to 20% of the causes of blindness. Followed by this, we have glaucoma, which is responsible for 6% of cases of blindness. Then we have retinopathy, which can be due to diabetes, hypertension, and prematurity. And then we have retinal detachment. Retinal causes are responsible for 5% of the cases of blindness. Then we have infections like trachoma. Then there can be trauma or congenital defects, which can be due to infections like rubella. Then we have the diseases of the conjunctiva and retina. Then there can be malnutrition. For example, we have deficiency of vitamin A. Now, lesser common causes in children include retinitis pigmentosa, retinoblastoma, retrolental fibroplasia, congenital glaucoma, keratoconus, and burns. So this is the pie diagram showing the comparison between the causes of blindness globally and in India. What is this avoidable blindness? Now, these are the blindness which could have been prevented or cured by reasonable access to affordable healthcare and includes blindness due to cataract, blindness due to infections like trachoma, then blindness due to vitamin A deficiency, due to glaucoma, ocular traumas, and then due to the refractive errors. Now, like any other disease, blindness also has an epidemiological triad. Now, agent factors we already discussed. Now, coming to the host factors, the first factor is the age. Now, causes of blindness among the adults is first, the foremost is the cataract. Then we have refractive errors, we have glaucoma, diabetes, and accidents. In children, the causes most commonly include the refractive errors. Then we have infections like trachoma, vitamin A deficiency, ophthalmia neonatorum, and congenital rubella. Now, the second host factor is the sex. It has been seen that blindness is more common among females. Coming to the nutritional status, malnutrition, especially deficiency of vitamin A, is an important cause of preventable blindness among young children. Coming to occupation, it has been seen that industrial workers are at a higher risk of blindness because of their work. Coming to environmental factors, the most important factor is the socioeconomic status. It has been seen that blindness is more prevalent among the lower socioeconomic class. Other environmental factors include illiteracy, we have ignorance, we have negligence, lack of knowledge, low level of personal hygiene, overcrowding, and non-availability of the healthcare services. Now, prevention and control of blindness can be considered under three heads. First, we have eye care, then is the specific ophthalmic programs, and then we have the rehabilitation. Now, coming to eye care, we have three levels of care: primary, secondary, and tertiary. In primary eye care, stress is laid on the promotion and protection of eye health, and interventions include vitamin A supplementation to the under 5 children, treatment of minor eye ailments like conjunctivitis, identification and referral of difficult cases, for example, corneal ulcers. Then is follow-up of beneficiaries, health education on personal hygiene of eyes. Now, this level of care is provided by trained primary healthcare workers like village health guides and multipurpose workers. On secondary eye care, there's early diagnosis and treatment of blinding conditions. And this level of care is provided by middle level health institutions, primary health centers, and district hospitals, and also by mobile ophthalmic units. Tertiary level of eye care is provided by the super specialists who are present in medical college hospitals, national institutes, and high-tech hospitals. In addition, these centers also provide training of health personnel and research activities. Now are the specific ophthalmic programs. Now, firstly, we have the trachoma control. The trachoma control program was launched in 1967 and was merged with the National Program for Control of Blindness in 1976. The ultimate goal of the program is to reduce the prevalence of blindness in the country from 1.4 to 0.3%. And this picture shows the logo for the program. Then we have the school eye health services, in which periodical examination of the children for general physical health and screening for visual defects is done. Promotive eye health services are also provided, like adopting good posture while reading and writing. Then we have the vitamin A prophylaxis program, in which 5 megadoses of vitamin A are administered to all children between 6 months and 3 years of age to control xerophthalmia and prevent nutritional blindness. Then we have the occupational eye health services. It consists of using protective devices, education of the prevention of eye hazards, and prevention of accidents by improving the safety measures of the machines. Now coming to the rehabilitation, it is provided to those who become handicapped due to blindness. This rehabilitation can be physical, in which we provide specialized eye care. It can be social, in which we try to remove the social exclusion due to blindness. It can be psychological, in which psychological support is given, or vocational, in which we train them for economically gainful employment. The schools have been established for blind where they are educated with Braille script. Train dogs and sonic torches also help them to walk through the streets. Other preventive measures which can be taken are installation of penicillin eye drops in the eyes of the newborn babies, avoiding high concentration of oxygen in managing low birth weight babies, mass chemotherapy of trachoma with tetracycline ointment, and correction of entropion, early detection and treatment of diabetes so that blood sugar is maintained at a normal level. Now, this Vision 2020 or the Right to Sight was a global initiative which was launched by WHO on February 18, 1999. Government of India launched the same on October 14, 2004 with the objectives to reduce avoidable blindness by the year 2020, and the goal was to reduce the prevalence of blindness in India to 0.5% by the year 2012, and that no child should go blind after 2012. For this, a four-tier structure was developed to develop the human resources, infrastructure, and technology, which included 20 centers of excellence, 200 training centers, 2,000 service centers, and 20,000 vision centers. This is the four-tier system. Now, Center of Excellence provide professional leadership. They develop strategy and also provide CMEs. They lay down standards for quality assurance and research. Now, training centers, they provide tertiary eye care. They also give training and organize CMEs. Now, service centers, they go for cataract surgeries, other common eye surgeries, provide facilities for refraction and also referral services. Whereas the vision centers, they do refraction and glass prescription. They provide primary eye care, school eye screening programs, and screening and referral services. Restoration of sight and blindness prevention strategies are among the most cost-effective interventions in healthcare. World Sight Day is observed on the second Thursday of October every year to raise public awareness of blindness, to influence the government to designate funds for blindness prevention programs, and to educate the target audiences about blindness prevention. Mobility of the blind people can be improved by providing them with a companion, which could be a long cane, an electronic device, or a guide dog, and imparting them sensory training so that the loss of sight can be compensated by the sense of touch and hearing. And also teaching them daily living skills, also called as the survival skills, which includes eating manners, using toilet, dressing, body hygiene, taking bath, and handling money. Now, as a public health person, it's imperative to talk about community ophthalmology. What is this community ophthalmology? It's a branch of community medicine that deals with the study of preventive, promotive, curative, referral, and rehabilitative ophthalmic services to the community. Or we can say it is a community approach aimed at improving the eye health of the community. What is the reason for this community ophthalmology? There are many people in the community who need eye care but do not approach the healthcare either due to ignorance, illiteracy, lack of knowledge, or poverty. And for every one patient coming to the ophthalmic clinic, there are about 10 people in the community who have some eye problem. And also, eye problem, it is not only an economic problem, a social problem, but it is also a health problem which can cause premature death. Now, aim of community ophthalmology is to provide ophthalmic services to the community at affordable cost, identifying and preventing blindness, and then reducing the disability due to poor vision. Now, community ophthalmology has four heads: preventive, promotive, curative, and rehabilitative. Now, in the preventive component, the interventions provided are ocular prophylaxis at birth, vitamin A doses, measles vaccine, perinatal care, avoiding of medication during pregnancy, and avoiding hypoxia at birth. Then examination of the eyes of the newborn. In the promotive part, the interventions include nutrition education, improved maternal and child nutrition, health education on eye health, face washing, good antenatal care, safe water, and improved environmental sanitation. In the curative component, the interventions include screening for vision, treatment for vitamin A deficiency, referral for surgery, treatment for trachoma, and treatment for other common eye diseases. In the rehabilitative component, the interventions include provision of low vision services, community based rehabilitation, counseling of the blind, certification of the blind, and sensitization about the various concessions. Now, here we see that community ophthalmology is different from clinical ophthalmology because here we have added preventive, promotive, and rehabilitative components, and also epidemiological research. And here the target is the entire community population and not only the patient who is coming to the health facility. And diagnosis depends upon health surveys and screening camps. Therapy includes health education and counseling in addition to the medicine and surgery that we are giving to the blind people. And the approach is community based. There's involvement of social workers and community volunteers. Patient mobilization is high compared to clinical ophthalmology. Accessibility and affordability is patient friendly. And the research interest is population based survey, and this whole program is community driven. In India, at present, we have only three centers who render this professional community ophthalmic services. We have Rajendra Prasad Institute of Ophthalmology, AIMS, New Delhi. We have LV Prasad Institute, Hyderabad. We have Lions Aravind Institute of Community Ophthalmology, and then Aravind Eye Hospital, Madurai. So by the end of this lecture, we have understood how we can be of some help to Abdul Ghaffar, who is suffering from most probably cataract because of the age factor. So I hope that this lecture has helped you in understanding how we can be of some help to people around us who are suffering from similar problems. Thank you.